Good afternoon, everyone, and thank you for joining today's webinar, Partnering to Treat Women with Opioid Use Disorders, Lessons Learned from a Six-Site Initiative. My name is Jean Blankenship, and I am with the Office on Child Abuse and Neglect at the Children's Bureau within the Administration for Children and Families. We are so pleased to have so many of you with us today to take part in this webinar, the second part of the webinar series that started on September 19th, with an overview and introduction to the newly released SAMHSA document, a collaborative approach to treatment of pregnant women with opioid use disorders, practice and policy considerations for child welfare, collaborating medical and service providers. We are happy to welcome you to today's presentation and to continue the conversation around this very important issue. This webinar series and the document is a collaborative effort between SAMHSA, the Children's Bureau at the Administration for Children and Families, and the National Center on Substance Abuse and Child Welfare. Today, we will feature 6 sites who have participated in the in-depth technical assistance program for substance-exposed infants through the National Center. The 6 sites include Connecticut, Kentucky, Minnesota, New Jersey, Virginia, and West Virginia. The National Center provided in-depth technical assistance to these sites as they work to develop a comprehensive service array across systems and working with pregnant and postpartum women with opioid and other substance use disorders, their infants, and their families. At this time, I'd like to introduce Linda Carpenter, who will be leading us through the next part of the webinar. Linda is the in-depth technical assistance program director with the National Center on Substance Abuse and Child Welfare, and has worked closely with many of the states who will be sharing their experiences, key findings, and lessons learned in the webinar today.
Thank you, Jean. Thanks for this introduction, and thanks also to Sharon Amatetti. I know she's not on the call today, from SAMHSA, and also to Elaine Stett from Children's Bureau, for not only their continued support for the National Center, but in particular their support and guidance on this particular issue. We're going to touch on a number of things today that these sites have done and learned over the last 2 years, but I want to point out the one bullet that says understanding current practice. I can't underscore enough the importance of the amount of time that these sites spent on this particular issue, not just in understanding practice in their own system, but in their partner systems as well. There was a tendency with these sites, as there oftentimes is, to want to jump in to implement new programs, to jump right ahead to fix something without always understanding what really needs to be fixed. The findings and the lessons learned from these sites have really helped to inform their next steps. It's really helped to inform their work across the collaborative systems, to understand each other, to understand the gaps and barriers that these women are often facing, and then to help them begin to look at policies and practices and even sometimes legislation that needed to be changed. Last week, we hope that most of you or all of you turned into the first webinar, part 1 of this 2-part series. And if so, you would have heard Sharon Amatetti and Dr. Nancy Young talking about the opioid epidemic, the impact on families, the impact on states and tribes and communities and systems, and especially on the child welfare system and the treatment system and medical systems. They discussed the work that went into the development of this guidance document and the expertise they relied on from multiple individuals. This document really set the stage for the work that we've done with these states over the course of the last 2 years. And we hope you've had a chance to download it and to really look and review this work. It's probably been one of the most critical pieces of information and guidance that we had on working with these communities. So the purpose of the Substance Exposed Infant In-Depth Technical Assistance Initiative, and I want to point out even the title with this, it says Substance Exposed Infant, and yet you're going to hear from all of us, and you'd hear certainly from each of the sites themselves, the importance of the mother-infant dyad, even the mother-father-infant dyad, triad, and the work with families themselves. This is not just about the babies. It's not just about pregnant women. It's about the work that we need to do to address the needs of pregnant and postpartum women, their infants, and their families. And so the work that's been done over the last couple of years, you're going to hear us talk about the knowledge gained with this, the lessons learned from sites. The focus was really on strengthening the capacity of these sites to serve these women and children and to improve outcomes for what we consider one of the most vulnerable populations. A little bit about our approach. You'll hear us talk about the site application, and we're going to talk at the end a little bit about some new opportunities coming up Sites were selected, and one of the first things that we did was to assign a senior level consultant, something that we call a change leader, to work with each of these sites. This change leader has years of experience, either in child welfare, in the treatment system, early education, and sometimes one or more than one of those different systems. We used a wide range of tools to help them identify issues and concerns. We focused on bringing together the right mix of partners. We helped them identify who those partners are and should be. We talked about where partners were aligned and where they experienced the greatest differences in approaches and values and perceptions in serving this population of women and their families. And that was it helped them form that collaborative to get started and look at who critical partners were and who missing partners were to do this work. When we start to look at the individual states themselves, I would really encourage you to pay attention to the depth and the breadth of the partnerships that were needed and are needed to do this work. Talk about a phased approach. I said they applied for this. And again, I can't underscore enough the importance of that needs assessment and that strategic planning piece. If you speak to individuals in each of these sites, they'll tell you that they're just now getting into that implementation phase. Working with our change leaders, they've developed some marvelous tools for conducting these needs assessments across multiple systems and then engaging in this planning process. You know, this is a time-consuming process. I said they wanted to jump right in sometimes to fixing the problem, but it really does take time. It was really important for them to understand not only how their systems work and how their systems were operating and the barriers and challenges that created for families, but it was also important to understand that sometimes how their systems worked could impede something that would be happening in another system. For example, if hospitals are not routinely notifying Child Protective Services when an infant is born prenatally exposed, then Child Protective Services can't respond to the needs of those infants and families, and they can't then report these births onto the Children's Bureau as they're required to do through CAPTA. We needed to know that. They needed to know that. We spent a great deal of time trying to uncover those practices in these various systems and looking at the way these systems are working in order to change practice and to work more collaboratively together. It took a lot of time. It certainly took collaboration, and in many cases it took a great deal of patience. Annabelle talked about these sites already: Connecticut, Kentucky, Minnesota, New Jersey, Virginia, and West Virginia. I think it's important to note, and again I'll go back to the webinar last week when Dr. Young was talking about the opioid epidemic across the country. If you look at where most of these states are clustered, they're along the East Coast or in the Southeast region with Kentucky. And then the Minnesota site really focused on the needs in the tribal communities and primarily the northwestern part of the state and the tribes. SAMHSA held a policy academy in August 2014. They convened 10 states, and it wasn't just to look at the issue of pregnant women and substance infants. It was to look at any number of different things that states needed to address related to the opioid epidemic. One of the opportunities that came out of that policy academy was really to focus then on this particular issue. So with the support through the National Center and with the additional support from SAMHSA, funding was allocated to select up to 6 sites. We solicited applications. We picked the 6 sites. They were awarded late October, started working with them in November. The original funding was supposed to be for 18 months. We would have finished up in about March 2016. We asked them to submit information to us in terms of progress that they've made, their additional goals, additional technical assistance that they needed. And then 5 of those sites moved on to continue with us through September of 2016. I'll say again, we're wrapping up with them right now in terms of this 2-year initiative. And I'll say they're really at the implementation phase. When you look at long-term systemic change, they've done a great job with forming these partnerships, identifying who all their partners are, expanding those relationships, understanding needs, and doing that strategic planning. And they're just now entering into the implementation. So So all of them will tell you, the importance of having some ongoing technical assistance and at least check-ins periodically would be really helpful at this point. But they've made some tremendous gains. They started with their applications with a range of different goals, and even though they may have been framed, each one of them a little bit differently, there are a great deal of commonalities and key issues across each of these sites. So they all, in some way, shape, or form, are working on a statewide action plan to address the needs of pregnant and postpartum women and their infants and families. You'll see where in a couple of our sites, and again, I'll go back to the webinar last week. We talked about medication-assisted treatment as being an evidence-based treatment. That doesn't mean it's necessarily accepted in every state across the country. So some of them really focused on building in medication-assisted treatment and having that accepted as an evidence-based practice. They're really looking at, they may have started wanting to focus on the infant or wanted to focus on the mother, the pregnant woman, but they really ended up understanding that what they needed was sort of a statewide system of care that extended in pre-pregnancy in a couple of cases, and certainly pregnancy through childhood. The development of consistent protocols, and you'll hear this, I think, from everybody who talks, the development of consistent protocols for early identification of both pregnant women and their infants became one of the most important things. They looked at, again, they looked at current practice, they looked at whether or not things were occurring and were they occurring consistently, and found in most cases that that was not the case. And so this became a really important focus for all of them. Understanding their financial resources, looking at financial mapping and where could they leverage resources across existing programs, and where were there gaps and barriers that they may need to ask for additional funding for. Data was a particular problem for all of them and continues to be a challenge, and not only data across systems, but data within their own system. So the importance of having some good baseline data on, how many infants are born prenatally exposed, and can we tell the difference between infants that are identified as being neonatal abstinence syndrome as opposed to infants that are born with fetal alcohol spectrum disorder, and do we have those numbers, and are those numbers consistently reported by hospitals and then on to Child Protective Services, and do we know how many pregnant women in our state with substance use disorders? And those were problems across most of the sites in terms of being able to have that accurate and timely and consistent data. So they're all looking at this. And then you're going to hear a couple of examples of where state legislation and possibly policies, existing policies and legislation, may possibly impede this work. And so the work that people are doing to examine their current legislation and examine their current policies, and then look at any changes that need to be made. I think with this particular slide, I'll just say that our change leaders become critically important in helping take sites through each of these phases. The facilitator's guide, the use of it, using a framework that I'm going to show you in just a minute, helping them build and sustain that team, and build and sustain that team in the midst of multiple challenges. So whether it's fiscal challenges, a lot of the states are going through massive turnover of not just frontline workers, but also key administrators and state leaders. And so how do you keep this work going when you have that kind of turnover? Again, how do you identify missing data elements, and how are you going to measure your progress over time? And then what tools did they have, did they develop, and did we bring to this to help them do all of this? We strongly, strongly recommend this structure. We strongly recommend building this structure with any of this work that you're doing, that includes an oversight committee that's composed of your policymakers, your senior leaders that help you address barriers, help you look at fiscal challenges, help you move things forward. And then a core team, and this is really your worker bees, your core team of either senior managers, mid-managers that really are working across multiple systems to identify and address these issues, and then to work on them. you're going to see a list of partners from each of these communities, and I think it still amazes all of us at the depth and breadth of partners that were needed to really address the comprehensive needs of these moms and babies and families. So in addition to that core team, amassing that both at a state and local level, all the partners that are needed to really address these issues. And then they broke into work groups. And so some of the work groups focused on data, some of them focused on legislation, some of them focused on actual programmatic practice changes. But it takes that kind of a structure to really do this work. And then the support of the change leader, working about 20% with these sites and really helping them with maintaining these teams and helping them with protocols and resources and research and any number of different things. Most recently, we've also started to look at the role of the state governors' task forces. Almost all states now have task forces that were formed to address the opioid epidemic. And usually those task forces are focused on addressing prescription pain medication monitoring, certainly focusing on the challenges with all of the overdoses and all the other things that are associated with that. Rarely do we hear state task forces that are really focused on this population of women and children. We've seen, however, the opportunity for, in this initiative, these folks, oftentimes someone might sit on that task force. So there's been an opportunity to form a subcommittee that really is addressing the needs of infants that are born prenatally exposed, pregnant and postpartum women with substance use disorders, and how do you highlight that issue to the level of the governor's task force and keep that issue in front of the governor and policymakers and all the other state leaders. So it's another level of engagement and oversight and connection that we have found really, really important in this particular issue. So we're going to do our first polling question, and we want to know, are pregnant women in your state or community routinely screened for substance use during pregnancy? So interesting results and not surprising. So are pregnant women in your state community routinely screened for substance use during pregnancy? We have about 31% of you who said yes. We didn't go so far as to say, are you using universal screening? Are you selectively screening? Is it all women that you're screening? But about a third of you are saying yes, 29% no, and then about 41% of you uncertain. And I think that uncertain becomes as important as looking at that yes or no. And that those responses are pretty consistent with what we found when we were first looking at this issue with states too. It's a good lead-in, that question is a good lead-in for me to talk about the importance of the 5-point framework. We use this framework a lot. I mean, we use it all the time with these sites. This is really sort of the basis of the work that we do. And not that every site was focusing on every single one of these intervention points, but they realized that wherever they were starting, whether that was starting at the birth of the baby or the postpartum period, or not the pregnancy period, the prenatal period, that ultimately they were going to need to address the intervention points across this continuum. So pre-pregnancy, the opportunity to really increase community awareness about substance use effects. And in this particular case, it was really helping the community better understand the effects of opioid use. The prenatal period, the screening and assessment period, this becomes one of the most important aspects of this work. Are we, as we just asked, are we screening pregnant women for substance use disorders and getting her, when positive, into treatment that she needs, appropriate kind of treatment, because that's going to improve outcomes both for mom and for the baby. Most often that identification comes at the birth event with the baby, and at that point in time it's critical to ensure that, and this is what Plan and Safe Care should do, address the needs of both the child and the parent. We're going to talk a little bit more about the postpartum period because it's a period where we're extremely concerned about women and their infants and children falling through the cracks at this point in time, and I think it's a period that we all need to be paying particular attention to. And then certainly that last and ongoing intervention piece, that infancy and beyond. Are we continuing to address the needs of that baby, that child, that family? from there on out. So this became really the framework for our work and helping sites really identify where they are, where they could start, where they could work with their partners. And I guess I'd ask as we go on to the next slide, look at this from your own perspective, from your own system, and see where are you right now and where might you partner with someone else to intervene at other points. Next slide, please. Do some existing policies inadvertently discourage pregnant and parenting women from seeking care for opioid dependence or other substance use disorders? Do you have this in your state? So again, interesting, not surprising results. Do you have policies that inadvertently discourage pregnant and parenting women from seeking care? About 46% of you said yes, and this could be any number of different either legislation, policies, practices that would, I mean, one of the things we identified was the stigma and the shame and the fear associated with using during pregnancy is much greater, I think, than any of us ever expected. We knew it was there. It's certainly much greater than we thought. And oftentimes what we put in place in our systems may not be supporting those women. They may be doing just the opposite and driving them away from care, driving them out of your state, driving them to other counties. And one of the things that we saw that was probably the most disturbing was even discouraging them not only from not seeking treatment for substance use disorders, but not even seeking prenatal care because they were afraid of what would happen with that. Again, the number of you uncertain, this is one of the discussions within the collaboratives. This was one of the most important first critical discussions around what are the policies and practices we have in place, and are they supporting these women, or are they inadvertently driving them away? So this is this same question from one of our sites, and it really depends on who's answering the question to begin with. You saw here the yeses, a little fewer yeses, a little more no's. A lot of folks from the treatment system were answering this particular question, but a lot of don't knows. And this was in the very early stages of our work, and it's why these questions became so critical. These are part of our guidance questions at the end of that document that Dr. Young talked about last week. Next slide. So now we're going to talk a little bit about the sites themselves. We'd like to take you through some of the lessons learned from these sites and the strategies and tools that they employed to address them. Again, many of the issues were common. We've picked out several key issues that we want to touch on within each of the sites, and we'll give you examples of how they address them. We've asked the change leaders to talk about the findings and what the sites did. But one of the things that I'd ask you to pay attention to as we go through these sites is to pay attention to the depth and the breadth of the partnerships that were formed. Look at all of the different partners that needed to be involved in this to really do this work, and the array of the partners. And one of the challenges for these sites was constantly going back, and the good news was they kept bringing on new partners. The sort of bad news with that was that they found themselves often stepping back and having to reorient or orient people all over again. But the depth and breadth of the partnerships with this has really been quite impressive, and it's been one of the most important aspects of this work. We're going to start with Kentucky, and actually Kentucky was one of my sites along with Annabelle. You heard Annabelle already on the phone. So Annabelle and I had Kentucky. And one of the biggest issues that Kentucky was facing when we first went there was the treatment system in Kentucky was typically an abstinence-based system, and they did not embrace, did not agree with, and didn't provide medication-assisted treatment as an evidence-based program. You heard Dr. Young last week talk about the importance of medication-assisted treatment as an evidence-based program for opioid use disorders, and particularly for pregnant women. The importance of getting women into medication-assisted treatment to support her health, mother's health, as well as the health of the baby is absolutely essential. That doesn't mean it's not controversial. It doesn't mean that everybody agrees with it. It doesn't mean that even within treatment systems you have agreement about medication-assisted treatment being an evidence-based practice or one that people want to use. Certainly was controversial with the child welfare system, the courts, some of the other, even some medical providers. And so this is an issue that Kentucky has been working on over the last 2 years. They've made some monumental change. They were awarded a couple of MAT expansion grants. They've got about 3 communities now that are really developing these really strong partnerships, providing medication-assisted treatment, providing residential care for moms and babies, and then transitioning those moms and babies back home to communities once the baby's born and moms and babies are stable. They have a ways to go, but I think it's been one of the things that they've made the greatest progress with. The array of partners in Kentucky, again, you can see they've got substance use, mental health. The Department of Public Health was in Kentucky, as well as all these sites, an absolutely essential partner in this, as is the child welfare system. Medicaid, having Medicaid at the table and being able to talk about, does mom have the appropriate coverage that she needs? When does that coverage end or change? In Kentucky, they also have the Office of Drug Control Policy, which ended up being a really interesting partnership because they were able to provide some data that maybe the other partners would not have had before. And then they had their programs and their community partners as well. We talked about tools. We worked with them, certainly with the guidance questions. This became particularly important for Kentucky, particularly with the discussion that we just had about medication-assisted treatment and the resistance to that, babies being born with neonatal abstinence and whether or not they should go home with moms, and all of the kinds of differences in values and perceptions that were there when we first went in. We did site visits, and then we used a process called the system walkthrough, where we really took them through every step of what happens with mom, what happens when mom, goes to an OB as she's screened, what happens when she goes to the hospital to deliver, what happens with the baby, and really trying to understand their current practices across multiple systems and how they communicated and shared information with each other in order to start to then look at changes in practice. Their goal, like all the sites, was to develop this system of care for pregnant and postpartum women. I think one of the things that made the Kentucky site unique in the way that they're approaching this is that they're really looking critically at the case management of these women from the beginning. They're looking at that critical postpartum piece and said up front that they were extremely concerned about what happened after the birth of the baby, and for both mom and baby both. What one of our consultants calls the 4th trimester is where we have really started to look at the fact that mom may lose coverage, or her Medicaid coverage may reduce significantly at a time where she's most vulnerable and the baby's most vulnerable, and who's monitoring them, who's supporting them, who's ensuring that they're still safe in care. And so Kentucky's looking at this over from the pre-pregnancy stage all the way, hopefully, through the first year of that infant's life, and really focusing their efforts on identification, case management, and then developing that plan for mom and baby both. In addition, they've done some great work with the hospitals, led by their maternal health, child and health director, of identifying hospital protocols. Are the hospitals consistent in the way that they're treating neonatal abstinence? They're working on a plan of safe care for infants and mothers right now. And it's important to note with that they're really looking at a multidisciplinary assessment process for developing that plan of safe care. So everybody that has a piece of information about that mom and baby in the beginning, whether it's substance abuse treatment, whether it's the hospitals, neonatologists, all of those various folks coming together and providing that information to develop that plan, develop a discharge plan, and then working with Child Protective Services, who's doing an interesting risk assessment process. We'll be doing an interesting risk assessment process with those babies and pairing those two so that they have a comprehensive plan of safe care that focuses also on understanding protective factors as well as risk factors, something they identified as never really having done before. And then the timing of that, making certain that they have that prior to discharge from the hospital so that they're certain when babies go home that they're going home safely, and if in the case they can't, then they go into out-of-home care, but mom's needs are still being addressed. You'll see the range of things that they've been working on in Kentucky. We talked about MAT expansion services. One of the things I want to point out with this is that they they looked at one of their current programs called the Kids Now Plus program, and they looked at how to leverage that program to serve these moms and babies differently. So they're retooling the program, they're retraining staff, and they're focusing much more on making that a case management and linkage services. No new money in this, same money, same program, but retooling and retraining staff to interface more with prenatal care providers and then to be that case management function for those pregnant women and their infants. And I also want to say the issue of changing culture, which has a lot to do with that medication-assisted treatment. There are challenges the same as with most of these sites, the early identification and screening, stigma, looking at whether or not moms had Medicaid coverage through the postpartum period, and then all of the collaboration challenges. Ultimately, what they expect to walk out with, and I know they will continue to work on this, is developing a statewide protocol for plan of safe care, the guidelines for the hospitals, and then practice changes across multiple systems for moms and babies. One more polling question. Think about your system and your partners. Are all staff supportive and non-judgmental about pregnant and parenting women with opioid use and other substance use disorders? Being honest about that one. This is a really important question, and it's one of the questions that is asked very early on in these collaboratives, and it's incredibly important for people to sort of look at this from their own perspective of what they think about women who are using during pregnancy. And again, I'm going to go back to the webinar that was done last week when Sharon Amatetti and Dr. Young talked so eloquently about the opioid epidemic and prescription pain medication, and how that's really helped people sort of think differently about this population of women and infants that we're seeing in this dramatic increase across the country. Understanding where systems are when they come to this work and what people think about this is absolutely essential. We talked about the stigma associated with this and the fear that women feel and face, having, whether it's fear of being arrested, whether it's fear of having your child taken away, which is the greater fear. It's really important that you have these discussions and talk about what you bring to this and what you think and what the right approaches are to this. But it is one of the questions that we use that's in the back of the guidance questions, and it's one of the most important ones that you can think about and reflect on with your partners. With that, I'm going to turn it over to Carrie Earle. Carrie is one of our change leaders with the Minnesota site, and she's going to talk about the work in Minnesota.
Thanks, Linda. So the one thing that we wanted to, as we went through and discussed the lessons learned from our sites, we captured themes, and one of the themes that sites can expect to, have to address are the barriers related to women and families accessing services that are appropriate for their needs and culturally responsive. And Minnesota, the work we did there and are continuing to do there is a really powerful example of the state working in partnership with the tribes within the state, with trying to look at what are some of the outreach and engagement issues related to engaging Native families, whether they live in rural areas or in the urban areas, on reservation or off reservation. And they also had a lot of interesting challenges related to the financing and reimbursement issues, given that tribes don't get financing for substance use disorders in the same way that non-tribe populations do. So there were some focus areas to try to overcome those challenges that were part of the work we're doing. And of course, related to the regional and cultural considerations, looking at the differences that families experience, whether they're in a remote rural population, small community. Sometimes those small communities have a lot of stigma attached to seeking services. So all of those barriers and additional ones as well became part of the challenge in that the Minnesota team needed to look at addressing and finding creative solutions to. We were really thrilled to see the growth of the partnership that developed over the course of the 2 years of IDTA in Minnesota. So the leadership was at the state level a partnership between Minnesota Department of Human Services, or DHS, and the Minnesota Department of Health. And those entities underneath that you'll see on the slide were comprised the oversight committee and the leadership team for the project. And then they, in partnership with tribes, both at the government level and service level and community leadership level, became really the overall core team and stakeholder group for the initiative. And over time it has now grown to well over 100 stakeholders that are continuing to provide input into how do they address these issues and come up with better services. So their application originally came forth because of disparities for Native women that are opioid using or opioid dependent during pregnancy, and the birth of the number of births that have neonatal absence syndrome is almost 9 times higher than the non-native population in Minnesota. So the application came forward in really focusing on wanting to address that disparity. There's a lot of other data that they have around higher rates of prescriptions of opioids for pregnant women for Native women versus non-Native. So they're significant health disparity issues. So around those issues, they created 3 overarching goals, and all of their work and work groups and action plans were organized around the goal of improving screening and assessment so that pregnant women, their infants, and their families are identified consistently across all of the systems and all of the communities. The second goal of fell under the topic area, the heading of joint accountability and shared outcomes, but looking specifically at how the state and tribe partnership can develop a collaborative approach to serve the women and the families that are at the intersection of multiple systems. And the third goal was improving capacity to deliver quality, culturally responsive services for pregnant women, substance exposed infants, and their family. So they used that focus area to start developing a guidance that could be adapted across communities and provide support in building up their service array. So through that original development of those goals, they developed an action plan, and these next couple of slides just highlight some of the strategies that they've identified for tackling the issue. So in addition to looking at the data, understanding where the substance-exposed births were occurring in the state geographically, and looking at what was happening from one region to the next, what were some of the differences and what was informing those differences. They also are developing outreach capacity by doing more of an expert approach and looking at different settings for implementing experts. Right now, the focus has primarily been up to this point around the prenatal care providers for doing expert, and so now they go beyond that and look at these other settings. Really wanting to engage law enforcement and understand how to educate and train, law enforcement for referring in a supportive way to make sure that women are engaged in services rather than in a punitive response. And finally, looking at those tribal and urban resources that can be responsive to specific needs that Native families have. I already talked a little bit about the financing issue, so they're looking at what are their reimbursement options for services like recovery supports and case management beyond just direct treatment services, and looking at how to develop strategic plan that increases availability and access to these services, really looking at the collaborative capacity building strategies that they can employ. Some of the challenges that they are continuing to address very specifically are developing a better infrastructure for the tribes to coordinate and collaborate with one another, looking at how to improve communication mechanisms and resource sharing, so that across the state, the multiple tribes in Minnesota are able to partner where it makes sense for them to, and also to borrow and share what they're doing that's working well in their own communities. There is an ongoing and very rich argument from one tribe to the next and from rural areas to urban areas about what the best approach is for working with opioid-dependent pregnant women. And so the ongoing work is to start really focusing on a strengths-based approach to what is working well versus focusing on those disagreements about medication-assisted treatment and some of the things that are deeply a part of their culture. Finally, really focusing on plans that are outcome-driven does become challenging, looking at the cross-section of the multiple governments that are represented through tribal councils, as well as all the government agencies at the state level. So the key considerations that are we've attended to with Minnesota are really looking at ensuring the spirituality and culture are at the root of all the programs that are part of the recommended best practices, looking at what's been effective and well done that encompasses the entire family in its approach, and aligning values across multiple systems so that their core values for the tribes of respect, humility, integrity, and sharing are reflected in the policies and practices that are being adopted. There's a huge need for one of those values to understand that interventions can't be global, that they need to be very targeted and tailored. But because there are two major tribes in Minnesota, they do tend to be good test points for interventions that are responsive and work well and could potentially be expanded. The most powerful thing that they always remind me of is that no matter how dire the data and no matter how frustrating sometimes the circumstances and the system barriers can be, their hope always transcends despair, and they're always optimistic in their approach for looking at what's going to work to improve the way that services are delivered and the way that outcomes are achieved.
I'll go ahead and do it, Carrie. Thank you. And thank you, Carrie, for that. So the last polling question, and it will certainly lead us right into a discussion with one of the other states, is does your state have legislation or policies that require a different notification process for infants affected by legal drugs, whether that's prescription pain medication, methadone, buprenorphine, as opposed to illicit drugs? And take just a couple of minutes to think about that. So 15% of you said yes, 29% of you said no, and the vast majority of you said you're not sure. So again, the uncertain, don't know, not sure answer is really important. It's important to know that not everybody understands this and to then find out about it. It's going to be really important as you're doing this work to say, do we have legislation, do we have policies, or sometimes do we even have informal or ad hoc practices that are causing us to respond differently to legal drugs, whether that's moms on methadone, moms on buprenorphine, mom's taking prescription pain meds, she's taking a prescription that was given to her by her doctor without looking at that in the context of all of the other safety issues and safety and well-being for both her and the baby. And so what we've found, and we found in these states, and we found in conversations with other states as well, is that most often the notifications were coming in around heroin. They were coming in, we'd like to say they were coming in around alcohol, but they're typically not. But they're coming in mostly around mom's use of illegal drugs, and not often when she was taking something that was prescribed. And in some cases, and we're going to go to Jill, and Jill's going to talk about her work in Virginia and New Jersey, in some cases there was actually legislation that made this even harder for folks to know what to do. And so as we uncovered practices with hospital notification and their notification to CPS, it was easy to see why a lot of times there's so much confusion around this issue. So I'm going to now turn it over to Jill Gresham. Jill Gresham is another one of our change leaders, works for National Center, and she worked with Virginia, and then she's also going to take you through New Jersey. So Jill?
Thanks so much, Linda. So Virginia came to the in-depth technical assistance effort with an intact work group that actually predated IDTA, and the work group was really assembled in response to recommendations that were provided by the Virginia Child Fatality Review Team along with the Virginia Maternal Mortality Review Team. So both of those teams really identified maternal substance use as a significant contributing factor in maternal and infant deaths. And in response to those findings, the work group was implemented. It was titled the Handle with Care Initiative, CARE standing for Coordinating Access and Responding Effectively. And so that work group really became a jumping off point for the IDTA. So you can see a lot of the partners up there represented on the Virginia Substance Exposed Infant Core Team. Many of those partners also inhabited the CARE team. So one of the standouts during that initial site visit, and I think Linda touched on this earlier with Kentucky, which is the high number of payers who showed up because they really wanted to be a part of this effort, as well as those staff from local hospitals and the hospital associations. Virginia was focused really early on in the initiative on the practices of hospitals at the time of discharge. And so this was in part due to a series of laws, which we're going to get to in just a moment. But the laws in a nutshell called for infants who were identified as being exposed to substances and their families to be referred to local community service boards, or CFBs, by those hospitals at the time of identification. So the CFBs in Virginia are, you can think of them as a single point of entry system, which provides linkage to substance use treatment, mental health, and early intervention services. Some CFBs directly offer treatment services, but the team really wanted to understand how hospitals identified those families and when and how those families then were referred to the community service boards. So the first step for the team was to develop this pretty fantastic hospital survey with the intent of distributing it across the state. The survey really looked at screening and testing practices. It also asked a lot of great questions about familiarity with those local laws, as well as some of the federal CAPTA laws specific to plan of safe care. And it really got into the nitty-gritty of what hospitals were doing at that discharge point in time and what the referral process looked like. Unfortunately, the survey actually met with some resistance among some of the collaborative partners, and it was ultimately abandoned in favor of a survey that would directly target the community service board. But not all bad news, because the survey actually went on to be the basis of a New Jersey hospital survey that we'll talk about in just a little while. So Virginia went on to implement a community service board survey, but they also really wanted to understand not only what was happening between the community service boards and the hospitals, but also what was happening between the hospitals and the opioid treatment programs and the medication-assisted treatment providers. So they started working on a survey as well to target the OTPs across the state. So, at the beginning of the IDTA effort, Virginia identified three goals. So you see the first one up there was to create a shared vision and coordinated systems approach to the treatment and identification of pregnant women and their infants. And the surveys really provided, or would provide, some baseline information about current on-the-ground practices, and with a plan to then develop some best practice guidelines for both systems, both for the CSBs and for the OTPs. And then a longer-term goal of how to really institutionalize some of those best practices, maybe through integrating them into standards of care or contract language. And the survey really also allowed the team to target outreach for practice change. So I think a good example of that comes out of the Community Service Board survey. The survey actually identified those hospitals that frequently referred infants with substance exposure versus some hospitals that had never really referred those infants. So the team really now has a list to be able to outreach to those hospitals who were infrequent referrals, so to really target some practice change. So Virginia also wanted to improve screening practices across the state, and this is also consistent with the laws that I mentioned earlier that are currently on the books in Virginia. One law mandates that all pregnant women are screened, but it doesn't go as far as identifying a tool, and there isn't any system in place to really track implementation. And the team really wanted to broaden the use of tools to identify pregnant women and ensure that they were referred to care. So I think we often wondered as a team, because the law in Virginia does say that screening needs to be happening, but what did that screening actually look like, and on the ground, what were doctors and nurses using as a tool? We sort of facetiously joke, did they ask clients, now you aren't doing drugs now, right? And just really understanding the vast difference between that approach versus using a standardized tool. We wanted to get some clarity about how doctors really were approaching screening. So you can see on the screen now the actual specific laws in Virginia that I referenced earlier. So that first law, really Virginia sought to ensure that all pregnant women were receiving screening for substance abuse and really to determine a need for substance abuse evaluation. So theoretically the screening was happening and then positive screenings were followed by a referral for an evaluation. That second law says that medical providers have to file a report with CPS if an infant is exposed to alcohol or other controlled substances. And then thirdly, this law specifically is the one that pertains to the Community Service Board, which is that hospitals must develop a discharge plan for identified pregnant women and then refer them over to the CSBs to implement the plan. So, when we sort of came into Virginia and heard about that these laws were on the books, there was a lot of excitement because it seemed really just right on target, and also in some ways seemed to be a stepping stone for a lot of the federal laws around plans of safe care. But we really struggled, the team struggled in Virginia because there wasn't a whole lot that sort of mandated that these laws actually happen. There was nothing sort of checking out to ensure that these screenings were happening and that they were evidence-based and the referrals were happening. So I guess we'll talk about this in the challenges section, but legislation isn't always the answer. It's how does that actually play out in the day-to-day? So we're on the highlight slide now. The core team then really developed two surveys. So as we talked about the CSB survey, which really focused on the relationship between hospitals on the referral process, and then the second survey went to the OTP providers and really asked about their work specifically with pregnant women, how they were educating pregnant women on neonatal abstinence syndrome, and then collaboration with the OBGYNs and medical partners as well as postpartum practices. I'm thrilled to report that the Virginia team was actually able to get a 100% compliance or response rate rather for both the OTP and the CSB surveys. So they learned quite a bit about current practices across the state. And again, even down to which of those hospitals were actually referring those infants and families to the CSBs and which weren't. And the third piece down actually at the top of the slide that you can see there is work on guidelines that were specific to developing a plan of safe care. So, a lot of what Virginia learned about what was happening in the OTPs and the CSBs is getting, again, filtered into the development of guidelines for a plan of safe care within the state. Part of those guidelines will include an actual discharge template that they're hoping to send out to hospitals, and that will be the discharge template that's used to refer over to the CSB. And really, it's in its earliest form, but could potentially be maybe the basis for the plan of safe care moving in the future. So challenges, the team concurrently has been working on guidelines for both the OTPs and the CSBs, even while those surveys were going out. The guidelines really focus on what information is critical to be shared. It focuses on really critical agency policies that support the work, and then partnerships really with the development of the continuum of care. so that both of those have actually been drafted, and the plan is now to have them reviewed by leaders of OTPs and CSPs. So this has been a pretty long and arduous process, but where it sounds like both those surveys will be reviewed by that leadership over the next month or so. And so then I think the bigger piece is how do we really then take those best practice guidelines and institutionalize them. And so this is going to be a longer process, but again, there's a lot of discussion about, how to take some of these pieces and flip this into some regulations so that they really can start to create some practice change. And then the next slide, key considerations. We were lucky in Virginia to have a site visit with all the community service boards, or at least most of them. And when the invitation went out, we requested that all the CSPs actually bring their partners with them, so child welfare, substance use treatment, their medical partners. And the teams came to the site visit and learned a whole lot about pregnancy and substance use and opioid use disorders. It was really apparent that the teams varied really widely in their level of collaboration. So some teams came, they were super integrated and had developed and already really even implemented super strong systems of care, while others were still getting to know their partners. So, as states really start to look at statewide implementation, it becomes really critical to understand the capacity and standing of local collaboratives, and implementation may look different in different communities. And, we touched on this earlier, which is that legislation isn't always the answer. Again, in Virginia, they had some really fantastic laws, but the laws weren't, rigidly followed and didn't really bring quite the change that they had intended to bring. So sometimes it makes a little more sense to focus on policy and practice implementation before jumping right to legislation. And then finally, as I was just saying, those guidelines are great, but they're a stepping stone to institutionalization. So, we heard from partners that guidelines might not likely produce that widespread change that we were after, but that it really needed to be integrated into some concrete standards. So a good first step, but they need to be vetted and bought into and, marketed to local organizations before they can be implemented. So New Jersey, I'm going to jump right into New Jersey. So one of the most notable features of the SEI IDTA team in New Jersey was its partnership. So the team was led by Chris Scalise out of the Department of Mental Health and Addiction Services, and they really, Linda touched on the importance of this, but they had a really extraordinary depth and breadth. So not only was it apparent across the departments and organizations who are participating, but also across leadership levels. So, going up as high as the Deputy Commissioner of the Department of Health. So the other thing is that New Jersey had a state opioid task force, and this actually existed prior to the Policy Academy. So Linda mentioned that the states who participated in IDTA actually participated in a Policy Academy. So New Jersey these members went to this Policy Academy and then came back and actually expanded the state opioid task force. And then additionally, there was communication between the opioid task force and the substance exposed infant in-depth technical assistance team. So there was a lot of good communication that was happening between those two so that initiatives can continue to be linked up. So, the team had a really marked ability to move the needle on some of these changes because of the levels of leadership that we're able to engage. So in the early days of the initiative, the team recognized that they had really limited information about what hospital practices were ongoing in terms of identification of infants and pregnant women with substance use disorders. When we talked directly with some hospital partners to try to delve in and understand what those practices were, it became really clear that there was a wide variation across different hospital systems. So an initial goal was really set out to understand how hospitals identified substance use, how they treated neonatal abstinence syndrome, so specifically, were they using pharmacological or non-pharmacological methods, that type of thing, and then what supports they developed to the discharge planning process. They also really wanted to understand the prevalence and associated cost of neonatal abstinence syndrome across the state. So they decided to tackle some of these issues, one by developing a white paper that was specific to cost and prevalence, and they were able to look at 2013 and 2014 data, and then to launch a statewide survey of all the birthing hospitals based on that initial Virginia survey that I referenced a while back. So you'll see up on the screen those initial goals that were identified by the New Jersey team. So that first one is really looking at increasing the prenatal screening for substance use disorder and multiple intervention points. So New Jersey does track quite a bit of their prenatal screening through the Department of Health. So they did have some pretty solid baseline indicators for doctors who were using the 4Ps Plus, along with some information about referrals that came as a result of the screening. So the goal was really intended to identify areas and organizations who were maybe not using the tool or not using the tool consistently in order to increase the prevalence of screening across the state. Secondly, they wanted to increase the referral of pregnant women who screen positive over to substance use treatment and evaluation. And then thirdly, to engage moms in care, but also to ensure that infants get engaged in care and early intervention services. So action plan highlights, you can see some of the highlights here. The survey itself was actually implemented over several months with a large group of collaborators. The group included multiple hospitals, there were state agencies, there were perinatal risk reduction coordinators, substance use treatment, medication-assisted treatment, among other organizations. So the team came together monthly. We were looking at drafts of the survey. We got a ton of input. We were able to do beta testing at 3 participating hospitals before creating a final draft. So that final draft actually went over to partners at the Department of Health, who then worked with some more partners at the American Academy of Pediatrics, along with some folks from the high-intensity drug trafficking area, including an epidemiologist who gave even more feedback and edits. And the survey is finally being reviewed by the IRB via Institutional Review Board before distribution to the hospital. So actually, the distribution has been pushed back to October, November, and is going to target the OB and nurse case manager chairs as well as pediatric chairs. And then the survey will also go out to community pediatricians at all of the birthing hospitals across the state of New Jersey. And then really we want to take that information from the hospital survey, one, to get a baseline, but then also to target hospitals and education around sort of best practices, and then also to start work on a statewide implementation of plan of safe care. And so getting on to challenges, I think one of the biggest challenges, even as we were developing the survey, was how the heck we were going to distribute it and ensure we got it to the right people at the hospitals. And that really, it was the AAP, the American Academy of Pediatrics, who came up with a fantastic solution. And they actually suggested breaking the survey up into sections, with a lot of the policy-oriented questions going to the chairs of pediatrics and the chairs of obstetrics, and then some of the more practice-oriented questions going out to community pediatricians. So we have 3 different pieces that are going out. The second challenge was bringing together such a broad cohort. So it was really critical to have the eyes of our agency partners, also the state partners, and quite frankly some of the hospital chairs and administrators to really help us zero in on some of those questions. They just had, a critical expertise that just brought so much depth to the survey as well. And then I think the third challenge lies in wait for the team, which is really, and I think that gets back to what I was saying earlier about Virginia, but how do we use this information that we gathered in the survey in order to really push practice change? So how do we institutionalize that change once we recognize and maybe develop some guidelines for best practice to not only change practice, but also in terms of development of the plan of safe care? So next slide, key considerations. Again, in New Jersey, having that cross-system oversight structure was critical to the work that they were doing, and that connection to the state level really helped us in terms of being able to get that survey out and to create some change. In New Jersey, we also had a really close working relationship with the medical community and the Department of Health. Really, it was invaluable. I cannot stress enough how having those partnerships with local hospitals that really the DOH and DPH has been, it's really invaluable. And really, it helped us, and I heard this several times in New Jersey, that working through the Department of Health, it really helped to reframe addiction as a public health issue and maybe start to move away from that stigmatized view. And then finally, states really need to spend time building that governance structure, and I think, again, we've we've been hearing about this morning, that we need to have that time to understand and develop governance structure before we jump right into implementation. And so with that, I'm going to turn it back over to you, Linda.
Great, Jill. Thank you very much. So the last state that we're going to talk about this morning, or work with states, is the state of Connecticut. And when Connecticut first came to this, they really wanted to focus on understanding substance-exposed infants in their state. They really wanted to look at the notifications that were coming from the hospitals. Were they getting the notifications that they needed, and if not, why? And then ultimately to work on developing a plan of safe care, and also understanding the difference between plan of safe care and safety planning for those babies and moms. The partners in Connecticut, and I'm going to go back to something that Jill said about New Jersey and Virginia, and I'll use this as a second to say that the National Center has had some years of history with many of these sites. We've worked extensively with New Jersey prior to this, extensively with Connecticut, with Virginia, and with Minnesota. So there was a lot of work done prior to this work on this particular initiative to help them build these collaboratives. The Department of Children and Families Child Welfare in Connecticut and the Department of Mental Health and Addiction Services had both worked together for many, many years and had some good relationships, some good partnerships. They'd done some developing of good models that they had jointly funded. So they had that relationship already. I think they were surprised, and later on pleasantly surprised, that they needed to bring so many other people to the table to address this issue, particularly when they started to look at, what's happening with notifications from the hospitals. Well, the hospitals needed to be at the table with that. One of the last site visits that we did with them, we had the gentleman who is the Connecticut Hospital Association director at the table, spent the day with us and talking about how to engage the hospitals. We had a representative from the American College of Obstetricians and Gynecologists, the American Academy of Pediatrics at the table, somebody representing New Haven Children's Hospital, their Hartford healthcare system, and I think Jill touched on in both New Jersey and Virginia the importance of having the managed care entities at the table, so that when you're talking about coverage for moms and case management services and all those critical pieces, are services paid for? Can she get the services that she needs? And those are the people that have control over those. Again, I don't think any of us can underscore the importance of public health enough of being at the table and part of this, because I think it was Dr. Brito in New Jersey who said, this is a public health problem. It's a public health epidemic. It's not just a child welfare issue. It's not just a treatment issue. It is a public health problem across all of these states and unfortunately across the country. We also had the State Department of Education, so early education. We had home visiting. They're absolutely critical partners, whether that's through the maternal child health system or the Department of Education, having them at the table, having the early intervention system. And one of the most interesting things in one of our last meetings in Connecticut was having the IDEA Part C people at the table, the early intervention provider system at the table, and the hospitals not even knowing, even though they feel they've done good outreach and education around this, that babies that are diagnosed with neonatal abstinence or FASD become automatically eligible for early identification services, for early intervention services. And so it was that kind of information sharing that occurred on a regular basis, and then what do you do with that information? How do you then build the system that needs to be built for these moms and babies? So in Connecticut, I said they had a strong partnership between substance abuse and child welfare already. We used another tool with them, the Collaborative Values Inventory, which asks a lot of the same questions, but even more questions that really get at, do you have the capacity to collaborate across systems to work on these issues together? What are the challenges and differences in values and perceptions that are occurring right now that we can highlight and uncover and start to address with you to make this work. We also used the cross-systems guidance questions. We did site visits, and as we did with the other sites, we did system walkthroughs. We did this a couple of times with them to really try to understand what are the practices that are currently in place in Connecticut. And it uncovered some really, really interesting information about, particularly about notifications, you know, how hospitals were dealing with babies and when those notifications were or were not made to Child Protective Services. Connecticut also took advantage of, and we encouraged everybody to do this, not to try to reinvent the wheel, but to build on something that somebody's already doing. So they also took the originally Virginia and then New Jersey hospital survey. They've adapted it for their own needs and have been in the process of disseminating that out to the hospitals in Connecticut with the goal of trying to understand what happens from the time that mom shows up to deliver. They're going to do a separate survey on prenatal and working with prenatal care providers, but this was really focused on at that hospital point in time where mom shows up to deliver. You know, does screening take place? Do we have prenatal history on mom in terms of any substance use? You know, what are the practices around testing babies? How is that information shared? And then what does it look like to make that notification and develop both a discharge plan as well as a plan of safe care. Like most of the other sites, their goal was to develop some guidance to hospitals and practitioners, and this came, they adapted their goals a little bit as they went, because as they did the needs assessment and as they began to uncover information, they realized that they needed to adjust their goals a little bit to really address the gaps and barriers that they were finding. So the need to really have some guidance to hospitals and practitioners, one, so that everybody was on the same page with CAPTA requirements and new CAPTA requirements. Do they understand what that means? Do they understand what a notification is as opposed to a child abuse and neglect report? Do they understand that it means not just infants exposed to illegal substances, but also legal substances, FASD, babies that are presenting with withdrawal, and trying to get that out to all the hospitals in Connecticut. They're really looking at developing this standard child welfare response and again working with the hospitals to understand the notification process, but really looking at what would a different response in Connecticut look like. And so they're trying to be extremely creative with this. They've looked at, you know, whether or not alternative response is the best pathway. Is there another notification process that occurs between the hospital and Child Protective Services, so that they're gathering all the information, and somewhat like Virginia and very much like Kentucky, one of the things that they're really taking a good hard look at is what information does child welfare need from the hospital when that notification is made. And this is extensive conversations, taken a long period of time in this state, along with probably their first and maybe one of their most interesting questions is, how are they defining substance-exposed infants? And they thought that was a relatively simple question when they started. It ended up being a very complex question, taking a great deal of time to reach some agreement across multiple systems. The hospital looked at that one way. Child welfare looked at it a different way. The treatment system looked at it a different way. So they all came with a different understanding and perception about what a substance-exposed infant was. It became really critical when they're sitting down and starting to think about what does that notification look like and what information do we need from hospitals to make that notification. What is the person on the other end at Child Protective Services asking, and what information are they getting in order to ensure the best response occurs at this step. And a good example of that, and this was a fascinating discussion among them, you know, in much the same way that Jill talked about with Virginia, if the hospital doesn't call because mom is already in treatment, or the hospital does call and say, I'm just letting you know that this baby is born, no need for you to do anything, mom's already in treatment, the response on the child welfare end has been okay, or sometimes that notification doesn't happen at all. And in working with them, we're saying, do you know what kind of treatment she's receiving? Is she in a comprehensive medication-assisted treatment program or a comprehensive program that's addressing her therapeutic needs as well as any medication needs? Is she only seeing a doctor for a prescription and maybe not connected to therapeutic services? Do we know, is she in compliance with treatment? Is she doing well? Do we know anything about the home environment? All of the other things that need to be taken into consideration when you're trying to decide what's the best next course of action for both this baby, the baby's safety, and the mom's safety, and the health of the mom and the baby both. So you can see where the complexity of this conversation has taken a very different turn from where they started with saying our hospital's notifying. Their action plan, obviously, to focus on a plan of safe care. I think the word complexity has come up time and again in each of our sites, where they talk about this is so much more complex than we originally thought it was going to be. It requires so many more partners than we originally thought, but I think the work they're doing around it and uncovering it and doing some very, very thoughtful thinking and planning about this is going to result in a really good model. They did a really interesting, what they call the ABCs of MAT training, recognizing that there was a lot of misinformation in child welfare, which led to some differences in perception about medication-assisted treatment. And so they worked with some treatment counselors in the state to develop this medication-assisted training called the ABCs of MAT training. And it was just marvelous. They were gracious enough to share it with us. We shared it with other sites. And they talked a lot about not only the training itself, but in discussion with workers around understanding and respecting various roles and responsibilities. So really understanding MAT and who makes the decision that mom needs to be on medication-assisted treatment. That's a decision with her treatment provider and her doctor. It's not anybody else's call to make that decision. The same with breastfeeding, understanding that unless contraindicated, it's okay to breastfeed under these conditions. That's a decision with her doctor, between the mother and the doctor. That's not somebody else's decision to say, no, she can't breastfeed. By the same token, it's child welfare's decision around the safety of that child. It's not the hospital's decision to say that baby's not going home or that baby is going home. It's recognizing that that's a child welfare decision in working in conjunction with the hospital and all the partners and having that information on a timely basis. So it's required these in-depth conversations across systems to really make certain that information is shared, the right information is shared in a timely way, and that they're working together towards the same end. They continue to work on the data collection issue. They've got a data work group, and they've been doing this data mapping process. One of the things that they uncovered in the very beginning, and this is one more type of a needs assessment, is when they looked at the numbers of babies born that were diagnosed with neonatal abstinence, and they had one set of numbers, and then they went back and looked in that same time period at the numbers of babies that may have been reported to Child Protective Services as being prenatally exposed. Those numbers didn't line up at all. And that was just with the neonatal abstinence, not even taken into consideration were any babies being notified in terms of fetal alcohol spectrum disorder or exposure to other substances. They needed to know whether that was misunderstanding about notifications, whether it was a data issue on their end when the call was made, was it coded a different way, but it really was an eye-opening experience for them about, they really didn't understand the depth and breadth of the issue that they were facing. They've also done some financial mapping. They're, like other states, they're trying to look at what resources do they have that they can leverage, what resources do they have that they can share across systems, and then go back and say, here's where we need some additional funding to address this issue. Challenges in Connecticut, probably the same challenges that we've talked about in most of the sites, certainly collecting that baseline data. Collecting that baseline data to understand what's happening in your own system, and then trying to share that data across other systems. So So do the numbers of women that entered treatment this year, pregnant women that entered treatment with a substance use disorder, how does that line up with the number of women that gave birth to a neonatal abstinence baby or another baby that was prenatally exposed? So do they have numbers that they can even correlate across systems, and do they have data that can talk to each other? They've got a data work group that is really making, I think, some fairly significant headway with this. And using that data, as Jill described with New Jersey, now can they use that data to really, one, describe their current practice and then start to inform practice changes from there. They have a governor's task force on opioids. They are now working to align the work around pregnant and postpartum women and their infants with other high priority goals on that governor's task force and making certain that they have a voice at that table. Connecticut's gone through a number of some pretty significant budgetary constraints in the last couple of years, and so, working on this and bringing partners to the table and talking about how do they work together to make these changes in the midst of some pretty dire budgetary constraints has been a challenge. But I think what's happened is that they are all on the same page with this issue. They're committed to addressing this issue. They recognize that this is an extremely vulnerable population, and they're committed to addressing it and moving forward with it. Key considerations for them, they're another one of our states where I think we're going to see an interesting model for what a plan of safe care looks like. They're in the process of working on that with their partners right now. They're developing guidelines, as we've heard from most of the other sites right now, for hospitals around the identification and treatment and management of neonatal abstinence syndrome. I think one of the things we didn't touch on that we've heard from most of our sites is the importance of managing these babies outside of a NICU environment whenever possible, and that's one of the things that has really happened in Connecticut, and we see improved outcomes for both moms and babies when that happens. They're looking at practices in hospitals like rooming in and all of the very important non-pharmacological supports for moms and babies that promote the infant-mother bonding at that point in time, and then developing those practices, implementing and making certain they're implemented consistently across the state, and then working on that. What does a multidisciplinary approach to a plan of safe care look like? And then rolling that out in a couple of sites before they try to go statewide with it. So that concludes our presentation portion of this webinar. What we wanted to do at this point in time, and we're going to take some questions and try to respond to a number of questions that have come through. Before you get off the line, we'd ask you to at least make certain that you do the evaluation at the end of the webinar. And then I think in order to pique your interest and encourage you to stay on through the question and answer portion of this, we're going to talk a little bit about an opportunity that's coming up for a number of states to participate in some technical assistance that we're going to be providing on this issue. So Han, questions that have come up during this presentation?
Thank you, Linda. We received several great questions throughout this discussion. But first and foremost, we've received several requests for the presentation and also several requests for a recording for today's discussion. The PowerPoint will be sent to you today, and a webinar recording will be available shortly after the conclusion of this webinar, and we'll make sure to send out both of those things to everybody who has registered. I think the first question that we want that the audience pose to the speakers is, are there lessons learned or experiences to share from any of the sites in implementing programs for medication-assisted treatment, particularly methadone, in rural communities? The person who is posing the question is experiencing challenges related to reaching a population that is widely dispersed over a large geographic area.
Well, I'll take a first crack at this, Han. I saw that Dr. Young is on as a panelist as well and may want to speak to this, and I don't know if Carrie or Jill have anything to say as well. I think that one of the and certainly whoever asked this question, if you would send us an email, we can follow up with you in a different way too. I think one of the states, Kentucky, is a really good one to look at with this. I said not only did they really not have much in the way of medication-assisted treatment, there was a lot of resistance about medication-assisted treatment, and they have a number of extremely rural areas in Kentucky. So even just reaching their population was incredibly difficult. They went for a couple of MAT expansion grants, and one of them they then placed in one of the very, very rural areas down in southeastern Kentucky. And they spent quite a bit of time sort of pulling together all of the community, working through some of the resistance with providers, certainly working through some of the uncertainties about medication-assisted treatment and preparing the community to embrace that modality. I think they've been relatively successful with that. And one of the things that they realized was because they have so many women, men as well, people with opioid use disorders in Kentucky that live in rural regions, the idea would be to serve them in their own communities, and that's typically what you'd want to do. They realized they were going to be oftentimes taking people out of their own community and taking them to a facility, a residential facility, where they could get this kind of treatment because they weren't going to be able to have MAT everywhere throughout the state. The other piece of that then is what is all the work that needs to be done to reintegrate them back into their community, to provide those additional supports and services that are needed to maintain their recovery and to continue to have them be successful with this. So they've looked at a number of different challenges with that, but I think they're one of the best examples of the work that needed to be done initially to even get it accepted there. And we'd be more than happy to make that connection with Maggie Schroeder in Kentucky for you to talk further about it if you're interested. Anybody want to add to that? Dr. Young or anybody else want to add to that?
Hi, Linda. Thanks so much. The other thing that I would add is to make sure if you're from the Child Welfare Agency that you have a partnership underway with your single state authority. There are many initiatives out of SAMHSA in expanding access to medication-assisted treatment. So if particularly related to the recent expansion of the number of patients that a doctor can have on his caseload who is prescribing buprenorphine. So if you don't have a partnership with your substance abuse and treatment agency at the state level or at the county level, I would encourage you to reach out and find out what initiatives they have underway to expanding access, and to make sure that that partnership includes this population of families that that need access to medication-assisted treatment.
And this is Carrie. I would just tag on to that the experience in Minnesota, they were really looking at a lot of telehealth options and working with the rural technical assistance providers related to that under the health department.
And
yeah, Carrie,
Jill, I would also.
I'm sorry, Jill, go ahead.
I think you'll probably know what I'm going to say, Linda, but also just remembering when we talk about medication-assisted treatment, it's not just, right, the medication, the dose of buprenorphine or methadone, but really what is that medication paired with in terms of an actual sort of psychosocial treatment experience as well.
Thanks, Jill. That was exactly what I was going to say, and I think it was one of the interesting lessons learned coming out of these sites is that for a lot of these people who were going for medication, those providers may not certainly be providing the therapeutic services, may not be connecting them to therapeutic services. So it's certainly a way of expanding medication-assisted treatment in rural areas, but making certain that they still have the connection to the therapeutic services as well. And mom is prepared for the birth of the baby and all of those other issues. So this is a team response. Han?
Yeah, thank you for that. And then it's great that I think all of the speakers and Dr. Young spoke to the importance of addressing stigma and training, which is a great lead-in to the next audience question. which is that a lot of tools and resources have been shared throughout this presentation. So are some of these resources and tools available so that communities can use them within their own communities? So some of the specific asks include that training, I think, from Connecticut on the ABCs of training, as well as the New Jersey hospital survey. So I guess the question is, are those resources available to communities?
Anybody want to? There are a range of National Center resources that I think are available right now. I think the New Jersey survey is still in its final stages. I think they're getting ready for distribution, Jill?
Yeah, that's correct. And I have talked to the New Jersey team, and they are more than happy to share that survey after it has been distributed in the state.
And we can certainly make that available at that point in time. Han, what was the other one that you asked about?
The ABCs of training.
For MAT.
Mm-hmm.
And we have gotten that from the person who worked with this child welfare system in Connecticut, and he was fine with us sharing that, and I think we've shared it with other folks as well. So we will make that available, I think, through Han, through you guys, through the National Center resources, and
yes, definitely. I think as part of the follow-up in today's webinar, when we send a PowerPoint, we'll kind of send out we will send out the PowerPoint as well as some of the resources that are currently available so that everybody who has registered for the webinar will have access to that. And so for those of you who are...
One more thing on that one, Han. One of the things that we always encourage, though, and I think Dr. Young said this when she talked about going back to, your own single state authority and understanding the treatment systems within your state, it's great to have this PowerPoint. It's a very good PowerPoint. We would strongly, strongly urge you to partner with either your state or your local treatment system to do that together. There will be questions that come up, and there are certain things in your own state that may be, nuanced in your own state that might be a little bit, so it's always good to have somebody who can speak to this from a treatment perspective, maybe doing this with you. So it's one more reason and opportunity to partner.
And let me just turn things back over to Han, because those of you on the phone, if you haven't reached out to the National Center on Substance Abuse and Child Welfare, Han Dow has all of the resources, I think, in the country about this particular topic. So Han, would you share a little bit about the resources that are available on the National Center website?
Sure. So many of you who are attending today's webinar may have attended the first webinar in this series. So that first webinar in the series was really a walkthrough of our most recently published and released document on these issues. It's really a document that helps communities, sites, and states really try to develop a collaborative approach to working with pregnant women with opioid and other substance use disorders and their infants. So that document contains a lot of great resources. So some of the resources that it includes best practices and evidence-based practices in the treatment of opioid use disorders among pregnant women. What are some of the best practices and evidence-based practices for infants who may have been prenatally exposed to opioids? The other great thing about this resource is that there are a set of concrete tools that communities can look to start kind of this process of collaborative practice. So Linda, Carrie, and Jill, I think throughout this presentation, really spoke to the need of conducting a needs assessment. And they shared several of the tools that have been developed and implemented throughout these states, right? Some of those needs assessment that Linda talked about include a systems walkthrough, as well as a New Jersey hospital survey. So there are certainly tools similar to that available to you as part of this comprehensive collaborative guidance document. So when I send out the email today, we're going to include the link to this comprehensive document that includes the concrete tools as well as a recorded link to the webinar that was facilitated just about 2 weeks ago that really walked through the tools and resources and even includes some detailed guidance and explanation on how the tools can be used, including I I guess, sequencing and as well as analysis of some of the results of the tools. Some of the other tools that we have available through the National Center is a comprehensive web-based resource directory that really focuses on these issues. So the resource directory is categorized into, I think, 5 or 6 different content areas at this point in time. So those content areas include best practices in the treatment of opioid use disorders, best practices in the treatment of infants who may be diagnosed with neonatal abstinence syndrome. We've included some examples from sites across the country that have started to work on this issue. I did fail to highlight the CHARM collaborative case study, which is part of the collaborative guidance document that we're going to send out today.
And there's also a webinar that was presented by many of the stakeholders in Burlington, Vermont, who for over a decade have been putting practice in place that engages pregnant women in a way that reduces the, if you will, crisis at birth for child welfare, that so that there is a plan of care prior to the infant's birth, and that the mother and the family are engaged in that assessment process and decision making about where the baby will go after birth, and child welfare has the opportunity to do that family assessment prior to the identification at birth. So many resources that are on the National Center website, and we look forward to also getting your questions about any specifics related to that.
Thank you, Dr. Young. So we received another question. Did any of the states who were discussed during today's webinar develop memorandum of understandings, and is it possible to get copies of some of those MOUs?
I think there are a range of memorandum of understanding that are in the process of being developed and protocols that are being developed right now, certainly depending upon what that piece of the system looks like. We've talked about the importance of the memorandum of understanding, and also I think when Jill and Ken DeSergio were in New Jersey a couple of weeks ago, they talked about the importance of even developing a charter between the various agencies with the commitment to address this population of infants and moms and babies. I know that Connecticut is in the very early stages of this, Han. Jill, I think with Virginia and New Jersey, they're still working on their guidance portion of that. Do you have anything to add to that?
No, you're correct. I mean, I think that Virginia is starting to finalize the guidance and start looking at standards. But just as you said, New Jersey is starting to talk about really developing a charter that would be sort of signed by all the different system
Right.
leads to maintain the work.
Right.
Thank you, Jill and Linda. And then as part of kind of the resource list that I ticked off, the CHARM collaborative case study in Burlington, Vermont includes an example of their MOU that has been developed between the collaborative partners involved in that partnership. The next question that we got is very timely to today's current environment with the passage of the CARE legislation specific to the captive plan of safe care. So the question is, how can state-specific policies on some of these issues that we've discussed today, including screening during pregnancy, access to medication-assisted treatment, and the infant notification to Child Protective Services, how can and are those types of state-specific policies and legislation, how can they be identified?
How can the policies be identified? How can the legislation be identified, Han? Is that the ask? How?
Yes. So basically, if somebody wanted to kind of figure out what are some of these specific legislations and policies within their state, what is the best way, or is there any guidance on how they can start that process?
I think that's a lot of the work. That's certainly the sort of the gist of the work that we have done with, I'm going to say in about 2 minutes, I'm going to turn it over to Ken and talk about the Policy Academy. I think that's the gist of the work that we've done with these sites in terms of bringing all of those key stakeholders to the table and everybody sharing those policies. I mean, you can certainly go back in your individual states and find out what legislation is in place, if any legislation is in place that either impedes or supports women, you know, getting services. So is there legislation in place regarding women's use, substance use during pregnancy? And we can help make that available too. With regards to some of the internal policies and practices, that's the conversation at either a state level across partners or a local level across partners of what are we doing, and that was part of our needs assessment. It was part of our walkthrough. It was part of our work with the sites to really begin to uncover that. I will say that in many of the sites when we first went in, even people within their own system, so I'm not going to pick on any one of these systems individually, but you could be from a child welfare system or a treatment system and not truly understand your own policies and then what does practice look like with regards to that. So we spent a great deal of time trying to uncover that and then understand it across the various systems. Jill, Carrie, either one of you want to add to that?
I think you
can.
Go ahead, Ken.
Hi, good afternoon, everybody. Ken DeSearch here. I work with Linda and the National Center on Substance Abuse and Child Welfare. I mean, the obvious place to go is into your state statutes or around child welfare, but there are a couple other documents to look at. The Children's Bureau just issued an information memorandum back in April, and then a more recent one coming out around CARA and the plans of safe care. And so each state's required to do a Child and Services Family Plan, each state child welfare agency, and this past June they're required to do an annual services and progress review. And so if you go into those documents and look for under how they respond to the capital legislation, plans of safe care, substance exposed infants, collaboration with substance abuse initiatives, under there you may find additional language in the protocols and how states have organized the responses to this issue and how states are responding to the requirements in the capital legislation. You also, in your Department of Health, the division that's over the maternal and child health block grant would have procedures, protocols for requiring notification to the state health department for infant births and the type of births, substance exposed infants, et cetera. And then be another place that you could look at their state plans and see what they say about responding and working around these issues.
Thanks, Ken. And I know Jill's got an answer to this. I'm gonna say one thing with regards to that. When you're talking about the notifications from hospitals, one of the things that we uncovered a couple of different times was hospitals saying, oh, my risk assessment department, my risk department is not going to let me do that, or it has to go through them, it has to be cleared by them. So understanding hospital protocols as well. Everybody, this was the thing, is everybody came with their own policies and procedures with regards to this, and it was really understanding not only what the child welfare policy was, but what was the hospital policy for even making that notification to begin with, and then what needed to change in both of those systems. Jill, did you want to add to that?
Well, and I think we got to this a little bit in Virginia, but sometimes the policies sort of come out sideways, I guess. I sort of think of it that way. I think there was a law that we looked a whole lot at in Virginia around how investigations were handled if an infant was born substance exposed but mom had attempted to or was in treatment, and how sometimes those moms really did need maybe an investigation or a couple more questions asked, but maybe it wasn't routine to sort of jump into that investigation. So the law was having some longer term implications that would then affect sort of the plan of safe care piece in terms of that reporting mechanism. So sometimes it's not just about like what is the law, but it's also how does it actually get implemented.
Exactly, and recognizing that what it looks like at the state level and what that policy or that legislation looks like, and whether or not that's carried out consistently at local levels across the state could very well be two different things, and that's where a lot of the understanding what practice comes into play. Han, I don't know if we have any more questions. I want to make certain that we leave at least a couple of minutes for Ken to talk about what's coming up next.
Well, it's actually the perfect time to transition.
Okay. So then I'm going to turn it over to Ken DeSercio, one of the program directors for the Children and Family Futures and National Center on Substance Abuse, Child Welfare, and will actually be taking the lead on this. So Ken?
Thank you, Linda. Good afternoon, everybody, again. Well, it's exciting for me to be able to announce, and perhaps this is the first time publicly we've announced the opportunity to give you the opportunity to expand the work that you're doing in this area, to expand our capacity to provide technical assistance around substance-exposed infants and prenatal exposure and the responses to both parents and children with these issues and developing plans of safe care. So with the support of SAMHSA and the Children's Bureau in the Administration of Children, Youth, and Families through the National Center on Substance Abuse and Child Welfare, we'll be organizing a policy academy in February of 2017, February 7th and 8th. In the Policy Academy, and you can see the title here, Improving Outcomes for Pregnant and Postpartum Women with Opioid Use Disorders and Their Infants and Families. It will give states, tribal nations, state child welfare agencies, substance abuse agencies, even large local jurisdictions the opportunity to develop an action plan to address the multiple needs and complex needs of this population. And through that Policy Academy, we give you the opportunity to think about what you want to accomplish in developing those action plans and what systems change you're hoping to bring about, you'd like to achieve as a result of participating in the Policy Academy. Applications will be forthcoming, hopefully in the next couple of days. We're scheduled to release those on September 30th. They will be released to the state child welfare directors, to the women's services coordinators within the state substance abuse offices, the state substance abuse directors. We hope to get these out to, again, to state public child welfare administrators, court improvement and administrative officers of the courts administrators, state and territorial health officials, as well as maternal and child health director. And if you're not on that list or don't know how to connect to those offices, if you send us an email when that Policy Academy application comes out, we'll make sure that we make that available to you so that you can engage the leadership in your states, their interest in perhaps putting a team together for the Policy Academy. There will be a selection of 8 to 10 teams to participate in the Academy with up to 8 team members to bring to Baltimore at the with the support of the National Center. The applications will be due on November 4th. The application will be anywhere between 3 and 5 pages, and what we send out on September 30th will detail the content of that application. The notification to successful applicants, the applicants that will be accepted, will be made in early December, and then sometime after that, probably before the end of the year, we'll have an orientation webinar for those jurisdictions selected. And at the Policy Academy, you have an opportunity to engage not only with those of us on the call today in the National Center Technical Assistance teams, but the subject matter experts and the consultants that have supported this work through our first round of in-depth technical assistance on this important issue, as well as the current in-depth technical assistance sites that will be represented at the Policy Academy. We'll give you an opportunity to engage and talk to them about their experiences in a little more detail to what you learned about today. And as you can see on the bottom part of the slide, funding and travel, lodging, per diem for up to 8 team members will be supported by the National Center. If you have any questions about anything you heard today, you can contact me at this email address. Also, we don't have it up here, I don't think, but the National Center website is ncSACW.samhsa.org. And as Han mentioned just a few minutes ago, that's where you can access the technical assistance resources that she highlighted, as well as all of the resources available through the National Center to Improve Outcomes for Children and Families Affected by Substance Disorders in the Child Welfare System. You can also send, in addition to sending me an email, or in lieu of sending me an email, you can send an email directly to the National Center with any technical assistance requests or additional information that you may like to have, and that will be, again, at ncsacw@cffutures, CFFUTURES, cffutures.org. So we hope that we encourage you to take a look at the application for the Policy Academy. We're excited for the opportunity to expand our technical assistance support to you. I forgot to mention that each of the teams will be assigned a change leader, and we'll have an opportunity to engage with the National Center after the Policy Academy. And then in 2018, we have an opportunity to apply to become an in-depth technical assistance site as well. And with that, I'll turn it back over to Han. Thank you.
Thank you, Ken. So that brings us to the end of our webinar. Thank you, everybody, so much for joining today's webinar. We'll make sure that we send out the list of resources as well as today's PowerPoint, the other webinar that was facilitated in this series. So thank you very much for your time, and we look forward to working with you in the future.